Buenas tardes a todos. I will now speak in English. Dr. Tom Carlson, Dr. Alejandra. So it is a great pleasure and a great honor for me to start this Easl symposium. And my first talk will be on the CPG Nafld guidelines and the other on the emerging treatments. So these are my disclosures. These guidelines have been published in 2016 and they were made together with two important European societies, the Society for the Study of Diabetes and the Society for the Study of Obesity. And during this presentation, I will also show some slides from the slide deck that is now in the Easl website. That's easy for everybody to use and to see. So the first point is the definition of Nafld. In fact, Nafld is a spectrum of disease defined by the excessive fat accumulation in more than 5% and needs the exclusion of secondary causes. It can be divided in Nafl, where we have only pure steatosis or steatosis and mild inflammation, and then the full-blown of necroinflammation, that is NASH, that can be non-fibrotic early with F0 or F1, or can be fibrotic F2 to F3, or really cirrhotic fibrosis. In either NASH or cirrhotic NASH can progress to HCC, what is a major worry in this situation. One important point, I said first that we have to exclude other causes such as alcohol. However, both alcohol and obesity can produce this spectrum of lesion from steatosis to steatohepatitis, and both can progress to cirrhosis and HCC. And the difference between the two of them is just based on this quite arbitrary consumption of alcohol of more than 30 grams in males and 20 grams in females to define either as alcoholic or non-alcoholic. However, we have been increasingly seeing a significant overlap of obesity and excessive alcohol consumption in inducing fatty liver disease. And we still have to see how useful is it to keep them separated or have them in a only entity. What's the prevalence of this disease? It is now it is probably the most common liver disorder in the Western countries. It affects about 17 to 46% of adults, and it parallels the prevalence, the increasing prevalence of the metabolic syndrome and its components, which also increase the risk of more advanced disease. However, Nafld, it's also present in 7% of the normal weight, the lean individuals. According to Yunussi, who was able to gather several studies from different areas of the world, and as you can see here, the median prevalence is about 25% of the population. However, some areas such as Africa have much lower prevalence, and others such as the Middle East, and what is of particular importance for this audience, South America has a very high prevalence of 30%, as was yesterday very well discussed by Dr. Mendes. What probably may have to do not only with the obesity, but also with some genetic predisposing factors. In Europe, Easl has commissioned to the UK Health Forum a large study on the burden of liver disease. And I'm showing you here some data. It has been recently published in the Journal of Hepatology. And what we can see here is that in Europe, Nafld NASH represents only a very small proportion of liver-related mortality. I cannot point out, but you can see that there are these very small red bars. So it's really a very small proportion. And this may be due to several factors. One is that the disease is not really identified by medical doctors. The other is that these patients probably die of cardiovascular disease, and so they don't really die of liver disease. And the other is that the codes, the codification of the disease is not done rightly in the ORBIT certificates. But if we have a so frequent disease, should we screen for Nafld, and who should we screen? And in fact, the majority of the scientific societies of the liver have stated that there is no role for screening the general population. There is a very limited value on that, and that is due to the high direct and indirect costs, but also to the low predictive value of the non-invasive tests, the risks associated with liver biopsy, but most of all, probably, is the lack of effective treatments. So the recommendations from the guidelines are that all individuals with steatosis should be screened for features of the metabolic syndrome independent of liver enzymes, and all individuals with persistently abnormal liver enzymes should be screened for Nafld. And then in high-risk individuals, such as those with type 2 diabetes, age more than 50 years, or the presence of the metabolic syndrome, it is important to find advanced disease and look for it. This has a very good grade of evidence and too as great a recommendation. The assessment of steatosis, it's still the ultrasound, the preferred first-line diagnostic procedure, since it also provides, it's non-expensive and provides additional diagnostic information. However, when the imaging tools are not available or feasible, we can use serum biomarkers, and scores are acceptable alternatives. Mostly in large epidemiological studies, this can be acceptable. A quantitative estimation of the liver fat can only be obtained by magnetic resonance spectroscopy. However, this technique should be used only on clinical studies or clinical trials, since it's in fact very expensive, at least for the moment. And what about pathogenesis? There are two major factors. One is, of course, the lifestyles. And we are very much aware that a Western diet and lifestyle has been associated with weight gain, obesity, and Nafld. Mostly associated with a high caloric intake, with the excess ingestion of fat, mostly saturated, but also high fructose intake and a sedentary behavior. So the recommendation is that first, and healthy lifestyles, in fact, play a role in the development and the progression of Nafld, and that the assessment of the dietary and physical activity should be part of the comprehensive Nafld screening. It has been also recently noted by Zelber Sagi, that has published a lot in this area, that also the consumption of the high consumption of red and processed meat, as well as unhealthy cooking with grilled or broiled techniques, is also associated with Nafld and with insulin resistance through these different mechanisms. Another important point are the genes. And in fact, several genetic modifiers of Nafld have been identified. However, only a minority has been robustly validated. And among those, PNPLA3 variant and TM6F2 variant carriers have been associated with a higher liver fat content and with an increased risk of NASH. And what is very interesting is all the different studies have been in agreement in considering these genes as a putative risk. However, at the moment, genotyping may be considered in selected patients and in clinical studies, but is not recommended routinely. What about the diagnosis? Liver biopsy is still essential for the diagnosis of NASH, because clinical, biochemical, or imaging measures cannot really distinguish NASH from steatosis. And Nafld encompasses steatosis plus one of lobular or portal inflammation or ballooning, and NASH requires steatosis and lobular or portal inflammation and ballooning. And NASH score indicates disease severity, although it should not be used for the initial diagnosis. However, it is impossible to do a liver biopsy in 1/4 of the population if we finally find this 1/4 of the population that has Nafld. What I think it's not probable, but what I mean is that it's not practical to do liver biopsy in the majority of the patients that present us with Nafld. So we have to use non-invasive assessments. And the non-invasive markers should aim to first identify the risk of Nafld among individuals with increased metabolic risk in primary care, identify those with a worse prognosis in secondary and tertiary care, as severe NASH, should also be able to monitor disease progression, predict the response to therapeutic intervention, and if we find this kind of methods, we could reduce the need for liver biopsy. And this is why there has been this consortium that was created in Europe, the Litmus, that is a very large consortium from the major centers in Europe that in fact tries to identify non-invasive markers of the disease and has been very well financed by the European Union, and it's a very, very interesting project. But coming back to the non-invasive methods, what makes it easier is that it was found that fibrosis, among the other histological aspects, is the one that in fact has an important prognostic significance. And there were 2 different studies published in 2015 that show this very clearly. This is the study from Angulo, where we see that it is in fact the fibrosis that defines the prognosis independently of the patient having or not having NASH. And the same was found in the Sweden study from Ekstedt and collaborators with a very large follow-up of about 26 years and a good number of patients. And again, it was the fact of having or not having fibrosis that defined the prognosis. And that is somehow good because it's easy to screen for liver fibrosis than for the presence or absence of NASH. And in fact, in this small publication, we have stated that there are very simple and inexpensive methods to screen for liver fibrosis that are the Nafld fibrosis score and the FIB-4 that are very easy to use in clinical practice and that can define those with a very low risk, those with an intermediate risk or with a high risk. And then we have more expensive tests, the complex patented tests such as ELF, Fibro test or fibrometer, and the FibroScan that at least in Europe is in a middle price, in a medium price, that can also be very useful to evaluate the degree of fibrosis. However, we have to be careful when using elastography, since it has been found that in Nafld it has a spectrum bias with cutoffs for the definition of cirrhosis ranging from 10.3 to 22.3 in different studies. So we have to be very careful when using them. So this is a quite busy slide, but I will try to go through it. So if we have patients with evidence, with imaging evidence of fat accumulation, defining them as Nafld, we really should rule out advanced fibrosis. And by the use of the Nafld fibrosis score and the FIB-4, we can have either what is in the green bars, that is about 55 to 58% of the patients that have very low scores. And in these patients, we could be quite confident that they are at a very low risk of having significant fibrosis, and we can just consider repeating the tests in 2 years and send them back to the general practitioner. On the opposite side, on the pink bars, we have those that have high values of the Nafld fibrosis score or of the FIB-4, that correspond to 12 to 15%, those are the ones that are in high risk and we should consider for liver biopsy. And in the middle, in the blue bars, we have the 30% that are in an intermediate stage or that have discrepant results from the FIB-4 and the Nafld fibrosis score. And in those, we could use other methods such as the fibro test, the fibrometer, or the elastography. And depending on the results, we could either consider them for liver biopsy or just consider repeating the tests in about 2 years. And what about the natural history of the disease? One of the major problems is the cardiovascular disease. In fact, that's the major cause of death in these patients, and the prevalence and incidence of cardiovascular disease is higher in Nafld than in the matched controls, and that is mostly driven by the association between Nafld and the metabolic syndrome components. So cardiovascular disease should be identified in Nafld regardless of the traditional risk factors. And cardiovascular disease and metabolic risk factors are also reported in adolescents and children with Nafld. So it's mandatory to screen the cardiovascular system in all individuals with Nafld because of the potential complications of cardiovascular disease, although we can discuss what would be the best way to do that. That's one meta-analysis that shows that, in fact, the risk of fatal and non-fatal cardiovascular disease associates with more severe Nafld. So it's not only Nafld, but more severe Nafld with a odds ratio of 2.5. Another significant and important complication is HCC. In fact, the cumulative incidence of Nafld-associated HCC varies according to the study populations, and a large number of Nafld cases are at risk of HCC, and so it makes quite impossible the surveillance of all these individuals. We know that the PNPLA3 variant is associated with an increased risk. However, and the guidelines state that very clearly, HCC surveillance in Nafld is not yet considered cost-effective at the present time. And now moving to treatment. So the diet and lifestyle are in fact the mainstay of the treatment and are mandatory in all patients. We know that modest weight loss is already able to reduce liver fat, improve hepatic insulin resistance, and can result in NASH regression. Weight loss of more than 7% associates with histological improvement. So the recommendations are that patients are recommended structured programs aimed at lifestyle changes towards a healthy diet and habitual physical activity. Patients without NASH or fibrosis still need to be counseled for healthy diet and physical activity, although no pharmacotherapy is necessary. And in overweight, obese, Nafld patients, a 7 to 10% weight loss is the target of most of lifestyle interventions and results in improvement of liver enzymes and histology. So this is the comprehensive lifestyle approach. So it's based mostly on energy restriction. The calorie restriction should be 500 to 1,000 per day, targeting again the 7 to 10%. And a long-term maintenance approach should be sought. Patients should avoid the fructose-containing foods and drinks. In what regards the macronutrient composition, it may be not make a big difference to choose diets that are more low fat or low carbohydrate, and it may depend on the preferences of the patient. It's more important to reduce the caloric intake as a whole. Then in what regards daily alcoholic intake, it should be strictly below 30 grams or 20 grams, but in patients that already have cirrhosis, it should be 0. Physical activity should be about 150 to 200 minutes a week, and it should be a mixture of resistance and aerobic exercise to promote musculoskeletal fitness and improve metabolic factors. When nothing is able to reduce weight, we can always have bariatric surgery. And in fact, the group of Philippe Mathurin has very well shown in this presentation in last ILC with a group of 198 patients with biopsy-proven NASH, that bariatric surgery was able to induce the disappearance of NASH in 85%. And what's more interesting is that this is maintained after 5 years. And the same with fibrosis, that was also reduced at 1 year and continued to improve at 5 years. So the guidelines state that it is an option in patients unresponsive to lifestyle changes and pharmacotherapy, reduces weight and metabolic complication, and has stable results in the long term. Moving now to pharmacotherapy, treatment should be indicated in patients with progressive NASH, with early stage NASH with risk of fibrosis progression, active NASH with high necroinflammatory activity. And the aims should be to reduce NASH-related mortality and progression to cirrhosis or HCC, and the resolution of NASH-defining lesions is accepted as a surrogate endpoint. We need to be careful about the safety and tolerability prerequisites. The two drugs that can be recommended is pioglitazone or vitamin E, although both have their problems. In fact, pioglitazone was abandoned in several countries in Europe and has a risk in patients with heart failure. And vitamin E should only be used in patients with NASH and no diabetes. In what regards the optimal duration of therapy, it is unknown, and in patients with increased ALT at baseline, the treatment should be stopped if there is no reduction of aminotransferases after 6 months of therapy. Finally, statins can be confidently used to reduce LDL cholesterol and prevent cardiovascular risk, having not much of an effect in liver disease. And my final slide to this presentation is that, in fact, at the present time, no medications are approved by either the FDA or the EMA for the treatment of Nafld NASH, and any drug treatment is off-label. And that moves me to my next presentation that I would now ask if you could put my next presentation, please. Because since we don't really have a good treatment at the present time, there is this great need for new therapies. However, the good news is that we already have a very effective treatment. In fact, this is from Vilar Gomes and Romero Gomes. What is shown here is that in the 10% of patients that are able to achieve a 10% weight loss, we have a NASH resolution of 90%, fibrosis regression of 81%, and steatosis improvement in 100%. However, only in 70% of the patients undergoing this kind of intervention only can get a 5% weight reduction. And with that, the NASH resolution and the fibrosis regression and steatosis improvement is in fact much lower. So although we know that there is something that is effective, we know that in most cases it doesn't work. And so there has been an enormous interest for the pharmaceutical industry to develop new treatments for NASH. And this I assessed 2 days ago in clinicaltrial.gov. What we can see is that there are now 561 clinical trials for non-alcoholic steatohepatitis. But I will not discuss with you all these clinical trials. You can be more restful. I will only focus on some of them. So there are different and several mechanisms of action that are potential targets for new drugs in non-alcoholic steatohepatitis. The major points, sorry I cannot point, are either through the metabolic sign, through the metabolic via, or the anti-inflammatory related targets, or finally the anti-fibrotic drugs. Because through all these mechanisms, we can have ways to resolve, or at least to try to resolve the problem. There has also been much discussion about what are the significant endpoints in the NASH clinical trials. And at the present moment, we have 3 important endpoints. It's the improvement of steatosis, the resolution of NASH, and the improvement of fibrosis. And most clinical trials presently are using single treatment modalities. However, combination therapies of multiple drugs to treat NASH are now being developed. Since, as you have seen, there are so many different mechanisms that it makes sense that we can have drugs that simultaneously affect metabolic pathways or the cell death signaling. So there are different ways in different forms of mechanisms. I will start with the phase 3 drugs. The phase 3 clinical trial studies. And I think these are the 4 most important drugs in clinical trials. So diabetic colic acid, OCA, elafibranor, selonsertib, and senicrivoric. Starting with obeticholic acid, it is an FXR agonist. The farzinoid receptor, the FXR, is a nuclear receptor that acts as a master regulator of bile acid metabolism and signaling. And it was shown to have several very positive effects in reducing inflammation and fibrosis, and also an effect on the carbohydrate metabolism. So clinical studies started, and probably the most important study was the FLINT. That's a phase 2b study. So in the study that has been published in the Lancet in 2015, what was found was that OCA was able to induce an improvement in aminotransferases and an improvement in several histological parameters, but mostly in fibrosis, and that is a very important point. However, it has 2 major downsides. One is that it has a significant number of patients that develop pruritus, and also it is associated with an increase in the LDL cholesterol, what is a major issue in patients that already have a significant cardiovascular risk. Although, of course, we can use statins, but that is really a major problem. However, coming from this phase 2 study, 2 phase 3 studies are now ongoing. One is the Regenerate study that is now enrolling patients. It's planned to have 2,500 individuals, all F1 and F3. That's one of the major issues, is that all clinical trials are in fact targeting F1 to F3 patients, at least the majority. However, they also are planning and already start recruiting 500 cirrhotics for the reverse study. And then we have elafibranor. Elafibranor is a PPAR alpha and delta agonist. It regulates multiple pathways that are essential in NASH. It has an effect in decreasing fibrogenesis, but also in decreasing oxidative stress and inflammation. And this has also a decrease in the atherogenic lipid profile. And so it could simultaneously be beneficial in what relates to cardiovascular risk. And in fact, there was a first phase 2 study, the Golden 505 study, where it showed a significant better reversal of NASH only in a post-hoc analysis. In fact, in the intention to treat analysis that was first planned, it did not reach statistical significance. However, a post-hoc analysis on the group of patients with NASH more than 4 and using slightly different endpoints, it showed a benefit in the dose of 120 milligrams a day in the reversal of NASH without fibrosis worsening. And so coming from this study, it is now going on to resolve it. That's elafibranor versus placebo. It's also a phase 3 clinical trial, planning to have 2,000 patients, again with a NASH score more than 4, and targeting F1 to F3 patients. It's being done in 20 countries in almost all continents: Europe, North and South America, Asia, Africa, and Australia. And there are expected results from an interim analysis. Also, we've noted that recently, in June 2018, a GenFit newsletter has stated that the administration of elafibranor prevented liver tumor development in Nafld NASH animal models of disease, what could be a good thing. And elafibranor also showed direct cytostatic properties in a large selection of human tumor cell lines. The other drug is selonsertib. It is an inhibitor of caspases, ASK1 inhibitor. It inhibits apoptosis, and it showed to be effective in improving fibrosis. In this study, in fact, it was shown that selonsertib was able to improve significantly more fibrosis than simtuzumab, that was then shown to be not effective at all. So it was used mostly as a placebo. It was considered as a placebo. So it was effective. And from that, Gilead developed two other studies, the STELLAR-3 and the STELLAR-4. The STELLAR-3 from non-cirrhotic and the STELLAR-4 for cirrhotic patients. The STELLAR-3 enrolled 800 patients with NASH with bridging fibrosis, and the STELLAR-4 883 patients with NASH-compensated cirrhosis. It is a 48-week trial, and the primary endpoint is 1 point decrease in fibrosis stage without worsening of NASH, ballooning, or inflammation. And the study's 5-year outcome is the reduction in progression to cirrhosis in the STELLAR-3, and of course in the STELLAR-4, the reduction of hepatic decompensation or hepatocellular carcinoma, transplantation, or deaths. So this already stopped the recruitment, but the study is ongoing. Finally, in this phase 3 studies, we have the Seni-Krivirok. It is a CCR2 and CCR5 inhibitor. There was the first study that is already published in Hepatology, but last spring, during ILC, Vlad Razio presented the 2 years results. And what they could see in the 2 years is that there was an improvement in fibrosis by more than 2 stages with no worsening of NASH. So if they looked only at the improvement of fibrosis in 1 stage, the difference was not really, there was no difference. And even here, the difference is not really significant, but it shows an important trend. And so the study is going on. And it's planned now, the Aurora study, that is a phase 3 study with 2,000 patients, again in patients with NASH with F2 and F3, and the primary outcome is the improvement of fibrosis without worsening of NASH. In the phase 2 studies, we have an enormous number of studies. I could not discuss with you all these studies, so I have chosen 3 of these that seem to me to be more promising. The first is liraglutide. Liraglutide is a GLP-1 agonist. It was studied in a small study, the LEAN study, that was published by Armstrong in The Lancet in 2016. And what it's shown, so the GLP-1 agonism is is an incretin mimetism that acts as an agonist of GP1 receptor. It has been used in type 2 diabetes since 2009. Here it showed a significant histological improvement of steatosis and NASH reversion in patients with NASH. And also, simultaneously, there was a decrease in the aminotransferases. The other promising drug is NGM282. It is a non-tumorogenic variant of the fibroblast growth factor 19 that modulates bile acid synthesis. It has been published now in the Lancet by Harrison that it associated with a significantly high reduction in liver fat in the treated arm. It's interesting that this study also used data from MRI PDFF and the results were there was a very good correlation. So I think this could be, in fact, a promising drug. The other drug that was presented again in ILC in April is the MGL3196. It is a THR-beta agonist, and it was shown to significantly decrease hepatic fat in NASH patients at 12 weeks, decreasing also LDL cholesterol and aminotransferases. As you can see here, the effect in fat reduction is quite impressive, and also it was shown that it has no effect on the thyroid function or thyroid hormone levels. These are the other studies. So there are several FXR agonists, non-bile acid FXR agonists that are now undergoing these phase 2 studies, but I will not describe them in details. There's another drug that is not so much talked about, that's Carbolife. Carbolife, it's a very interesting and different drug. It's an oral nanoporous carbon that is able to put endotoxin inside it, so reduce endotoxin in the intestine, and it shows considerable promise as an oral non-absorbable intervention strategy. There's also a consortium in Europe, and we are about to start a clinical trial not only in cirrhotic patients, but also in patients with NASH, non-cirrhotic, but it's through a very different and interesting mechanism. I will show you also this slide from the Kahneman manuscript on the Journal of Hepatology that summarizes most of what I said here about the emergent treatments. As you can see here, these are not comparisons head-to-head, but so there are very different levels of improvement with the different drugs in what relates to the improvement in hepatic steatosis, or the resolution of NASH, or the improvement of fibrosis. However, if you look on the improvement of fibrosis, that's probably one of the most important endpoints. Only for OCA and for Senicrivoric, there was seen some significant improvement in fibrosis. But if you compare this with the effect of the weight loss and the lifestyle interventions, these are much worse results than those of the interventions. So I'm moving to the end, and my take-home messages are that we now have a very large number of promising phase 2 and 3 clinical trials that are ongoing, and results are eagerly attended and expected. However, there are some major issues regarding these clinical trials. One is that there has been difficulties in enrolling patients or in finding patients to enroll. And this is probably because there are difficulties in identifying patients. And although we may say that 1/4 of the population has Nafld, this is in the epidemiological studies. It's not that these patients present in clinical practice. But then there's also a great difficulty in stratifying risk to identify the patients that really benefit from drug treatment. And I can tell you from my experience that from a large universe of patients with Nafld, we then come up with a small percentage of patients that really would benefit from treatment or would have the criteria to be enrolled in these clinical trials. So this is a major challenge. And the other challenge is that for the time being, the majority of these trials use multiple liver biopsies. Either Regenerate or Resolve, it have at least 3 liver biopsies. And so patients are not usually very happy with that idea. But hopefully that will change in the future. We will find good and reliable non-invasive methods to be able to do these clinical studies. However, even if very effective drugs are to be found and confirmed, it will be still difficult to define the treatment time. Are we going to treat these patients forever, as we do with diabetics or hypertensive patients? Because, of course, it will tend to recur if the risk factors remain. And so what I think would be really important is the political measures that would be able to revert the epidemics of obesity all over the world. Thank you very much.